Hello, and welcome to this National MS Education Awareness Month teleconference hosted by MS Focus, the Multiple Sclerosis Foundation, and made possible with support from Biogen, Novartis Pharmaceuticals, EMD Serono, Genentech, and Sanofi Genzyme. I'm your host, Casey Minnis, Director of Communications for MS Focus, and I'm joined by Jennifer Smrtka, Advanced Registered Nurse Practitioner, who will discuss the topic, the importance of building a healthcare team. Please note there are slides available for this presentation. To view them, go to readytalk.com and join with the access code 7766805. For those writing that down, that's readytalk.com and the access code is 7766805. Now, allow me to tell you a bit about our speaker. Jennifer Smrtka is a board-certified nurse practitioner and certified multiple sclerosis nurse. She's worked exclusively in MS since 2003 as a clinician, clinical instructor, consultant, and a clinical research investigator. She is a board member of the International Organization of Multiple Sclerosis Nurses, and she currently works at the University of Miami in the MS Center of Excellence. We're delighted to have her with us tonight. Ms. Smrtka, thank you for being here, and I'll turn it over to you.
Great. Thank you so much, Casey, and good evening to everyone. I just wanted to, first of all, thank the MS Foundation for inviting me to speak to you this evening, and to thank all of you for joining, hopefully after a dinner or work, and also to the pharmaceutical companies who generously donated to fund this program. As you know, it's MS Awareness Week, and so we are really in the spirit of finding a cure, really looking to see what we can do to manage this disease as opposed to having it manage us. So I think this is a great program of changing the focus and kind of seeing how we can better manage MS as you're living with it until we find a cure. So if those of you that are following along on the web, I will be kind of advancing the slides. And for those of you who are just listening, I will try to take my time and speak slowly so that if you're taking notes, you have the opportunity to jot some things down. Those of you who know me know that that is going to be very challenging because I like to talk fast. I have so much that I want to say. It's hard for me to try to remain measured in my cadence and my speaking, but I'll do my best. So let's move on. First, just the topic really tonight that I want to spend the most time on is really the importance of building a healthcare team. And so I will spend a lot of time on the back end really discussing that piece specifically. But for those of you who are joining with respect to anyone who may be newly diagnosed or new to the MS community, I would like to provide just some overview. And for those of you who've been living with MS for many years, who I also consider experts in this disease and pathology, this most surely will be a review for you. So again, just to turn some pivot and turn focus on the fact that the definition of MS really has remained the same since it was first well characterized in the late 1860s by Dr. Jean-Marie Charcot. It is still considered a inflammatory and a neurodegenerative autoimmune condition. It is, in fact, the most common chronic disease that is affecting the central nervous system in young adults. We certainly see MS across the lifespan. Unfortunately, we have pediatric MS. In fact, we have 5 pediatric centers of excellence across North America. And we actually see patients living late into their 70s, 80s, and 90s with this disease. In fact, my oldest patient in my practice is 89, and the oldest patient that I have diagnosed was 82. So we still make the diagnosis, quite frankly, at autopsy. people may have lived their whole lives with it, really not realizing that's what they have. It is immune mediating, meaning that the immune system misinterprets the components of myelin and axons as something it has to attack. And the misconception often is that somehow you're immune suppressed having MS, and that is actually a fallacy. We know that patients living with MS actually have an overly active immune system. And we do know now that it's precipitated by some environmental factors, some of them unknown, and some of them have been identified. And certainly there is a genetic predisposition with some patients of Caucasian descent. It is considered both simultaneously an inflammatory and a neurodegenerative disease, because we know very early on that we have axonal loss, and unfortunately that renders some patients permanently disabled. In terms of the epidemiology, this is a very old census. In fact, this census was originally conducted in 2005, and that was also based on some data material. So it's incumbent upon us to really have an updated census, and I can tell you that at the University of Miami, they're working on some research with the NARCRIMS database to try to get a much more updated representation of what the true numbers are of cases of MS that have been identified in the United States as well as globally. But based on the data that we have, we say that there's approximately anywhere from 2.5 to 500,000 cases in the United States, and the probability is around 2.5 to maybe 5 million cases worldwide. Now, I always say, let's put this in perspective, right? Because we know MS is the most common non-traumatic neurological condition affecting MS, and you know as well as I do, as soon as you were diagnosed with MS, it seemed like everybody was coming out of the woodwork, knew somebody who had MS, and you think, gosh, this seems like such a common disease. In fact, it probably is still considered a rare disease despite the numbers that you're seeing, okay? So to give you some perspective, the numbers worldwide are estimated to be 2.5 to 5 million cases worldwide. If you put that in reference to the population in New York City, the 5 boroughs, we have about 9 million people living in New York City. And when you think of 5 million people in the world living with MS, it's still considered a relatively rare disease. Okay, we do know that there is a higher incidence of occurrence in women more than men, still 2 to 3 times more than occurring in women more than men, and the majority of cases are presenting with symptoms between the ages of 15 to 50. Again, I told you there are outliers. We do have pediatric populations, and we also have geriatric populations. And most of you living with MS, if you've been diagnosed recently or within the age of the disease-modifying therapies, the likelihood that you're going to live a long life with MS is great, because with us treating earlier and more aggressively at the first sign of diagnosis, people are living much longer with the disease and not seeing an incidence of shortening of their lifespan related to MS. So the pathophysiology of MS, again, we know that there is some reactive agent within the periphery, okay, where the immune system is doing its normal surveillance, looking for things like infectious agents of bacterial, viral, or fungal infections, and something, and we're unclear as to what, kind of instigates the immune system in the periphery. Okay, may have been some genetic predisposition, may have been some infection, but something turns the immune system on. Okay, and there's a disruption in the blood-brain barrier, which we now believe to really probably mostly reside within the gut. And that blood-brain barrier shouldn't be permeable, but in people affected with MS, that blood-brain barrier is permeable. So those activated immune cells that are in the periphery and pro-inflammatory are able to cross over from the periphery with into the central nervous system. And once they do that, they cross the blood-brain barrier and they get reactivated in the central nervous system. And once there, they become programmed to destroy myelin. Okay, so they attack the myelin sheath, and unfortunately, with such aggressive vigor, they also can affect the underlying axon. Okay, and cause destruction and degradation to the axon as well. Okay, in terms of symptoms of MS, we see kind of primary, secondary, and tertiary. And how we kind of classify that is that primary symptoms are things that are direct results of multiple sclerosis. So, for example, that would be fatigue, for instance. The majority of people living with MS pretty universally experience fatigue that's more like lassitude or an inability to be refreshed with a nap or even 10 or 12 hours of sleep. It's just this metabolic decrease in energy where people just feel run down, or I've heard it explained as feeling unplugged. Okay, we can see some cognitive changes too, certainly related to that fatigue, and also later on in the disease process, if somebody's not treated, we can see some cognitive changes. We certainly can see things like altered vision or pain or spasticity or altered mobility. Secondary symptoms are a result of the primary symptoms. So, for instance, if you have weakness and a gait impairment, you're at a higher likelihood of having a fall. The fall itself would be a secondary symptom of the primary symptom of weakness. Okay? And then tertiary symptoms would be more of those outcomes of the disease process, more of the psychosocial aspects of the chronicity of the disease. So we may see some job loss or job change due to significant fatigue or inability to perform at the level that you had once performed at, or a loss of self-esteem because you're constantly feeling like you're having to adapt to changes that are feeling out of your control. Okay, there can be certainly a lot of family disruption and role changes with care partners, and a sense of having to depend on people where that may be really uncomfortable for most people. So in terms of how we classify MS, we're kind of starting to move away from those classic phenotypes of the four types of MS, of relapsing, remitting, secondary progressive, and progressive relapsing, for two reasons. One, they were originally described by Dr. Loveland and Dr. Reingold really for the purposes of clinical trial investigation, to be able to kind of classify and categorize MS to see, really to trial the medications. As a result, many of you are aware that the insurance companies have kind of infiltrated and manipulated those phenotypes to their advantage, say it that way. And we really know that actually inflammation and degradation are occurring simultaneously from the beginning. So, there's really two types of MS. There's progressive and non-progressive. And most likely, it's really a syndrome as opposed to phenotypes or classification. And Dr. Loveland went back in 2013 and kind of revised the phenotypes and removed the progressive relapsing category. So, and actually in place of that, put in clinically isolated syndrome suggestive of MS. This is when you have your first clinical incident or first clinical manifestation of the disease. And we start treatment actually immediately once we have determined that this clinical event or these presenting symptoms are consistent with what we determined would be MS by MRI, by your clinical history, and we ruled out any other possible explanation. We actually start people on medication as soon as we're able to identify them as the CIS. Okay, the majority of people do fall into the relapsing remitting description in that they have classic periods of acute symptoms, and then they will kind of remit over time. They may not go back to their normal baseline, but they aren't having progression or worsening in between. They may have some residual symptoms, but those symptoms aren't worsening. And then certainly the progressive disease where you do see worsening. And very few people have what we call primary progressive, or truly from the very beginning of their disease, are just insidiously getting worse over time, where there's never any area or period of time where they actually have any quiescence. So Dr. Krieger, who's actually Dr. Lublin's protege, put out a beautiful topographical model of MS in late 2015, early 2016. And I think, honestly, that's probably the best depiction of what we know about MS in terms of, from the very beginning, we know there are MRI changes before somebody even presents with clinical manifestation or clinical symptoms. And over time, if we do not treat the initial inflammation or destruction of the axon, people can have symptoms accumulate and disability can progress over time. But what's interesting is Dr. Krieger's model, if you haven't had a chance to look at it, try to Google it after we're done. It's extraordinary, and I think it's again, a very good characterization of what we know about MS. In that he has it set up almost like a pool, okay? And as the clinical reserve, which is the water in the pool, starts to descend, you see kind of this breach of the surface with relapses. And many of us have compensatory mechanisms. So our bodies will try to compensate for disease activity. And over time, if we don't treat the disease, it catches up with us. And we really are very focused now as clinicians in treating people as early and as aggressively as we can, because we know that time is tissue. And what we lose, we may not get back. And I always tell patients that I am praying and I'm hopeful that we will have a cure in my lifetime. But a cure will not help somebody who does not have anything to treat. So the important point is that we treat early on aggressively and try to preserve as much brain volume and brain function and brain tissue from the outset. Okay, so now I want to kind of pivot and move into really the meat of our discussion. I just wanted to really give kind of an overview of what MS, kind of the definition is. But now I really want to kind of transition into managing the MS. And I think over time, what I have observed in my clinical experience are these kind of 4 ways to try to optimally manage MS. And the first thing, and I'm going to spend the most time on that, and I'll kind of briefly outline the other 3, is really identifying who is the appropriate team to surround yourself with, and how to utilize that team to the best of your advantage to obtain the best possible outcome for yourself living with this condition. Okay? In terms of pharmaceutical treatments, and again, I'm going to gloss over these last 3 bullets from the standpoint of these are things that you guys have probably heard an innumerable number of times from different talks that you have attended. But, we know that the pharmaceutical treatment options are varied in terms of their route of administration. We have injectable agents, we have oral options, and we have infusion options. And we remarkably have continued to add therapeutic options to the landscape in a really expedited fashion. I mean, when you consider, again, perspective, 1868, this disease was first described by Dr. Jean-Marie Charcot. We go from 1868 to 1993 before we have any means of actually modifying the disease. Okay, so 1993 is when beta-serum was first introduced to the U.S. market. We go from 1993 to now 2017, and we have 15 FDA-approved therapies. We may have another therapy approved by the end of this month. There are several more kind of waiting in the wings that perhaps will be submitting for FDA approval within the next 18 months. And very rapidly, in a relatively short amount of time, we now have a plethora of drugs to choose from. And all of the drugs that are FDA approved have been clinically proven to work, okay? And I prescribe all of the drugs for the most part and use all of the drugs. And what I say is this with the patients that I have the privilege to work with is that we know all of these drugs work, but all of these drugs don't necessarily work for everyone. And MS is a very highly individualized specialty, and there is no cookbook recipe to treat MS. And if you had a room full of 10 people or 15 people who all had a relapsing form of multiple sclerosis, and we went around the room and we asked every person to tell their journey with MS, it would look so different. It's as individual as your thumbprint. And so the treatment usually is as individual as your thumbprint. So it can be frustrating when you go to different support groups or you go to different educational dinners and you hear that this drug must be great because it works for this ambassador, it works for this person. That may not be the way it works for you. And there was some news that hit the news agency wires this past week talking about biomarkers and taking the blood test and trying to kind of determine which therapy would be appropriate for a person based on their genetic makeup or their genome. And we don't have, it's not available in the States currently. It's being looked at in Australia. But that's something that we are certainly kind of looking towards in the future. We'll be able to hopefully identify biomarkers that would help us to better determine who may respond to a type of drug and have a better response overall than just kind of doing it how we do now, which is we look at your lifestyle factors, we look at your concomitant, medical history, any other medications you're taking, any relevant family planning that might be coming into play, and certainly can you afford the medication. These are all things that we look at in terms of trying to determine what is the best treatment option for you. And once we've decided to go that route and we treat with a disease-modifying therapy, when necessary, we may also include symptom management, okay, which may or may not be long-term in terms of putting you on an additional medication. Generally speaking, with respect to symptom management, I try to treat the symptoms for 6 weeks in my practice and then have the patient come back and see how are they responding to the symptomatic medication. And if they are having a good response or the symptoms are seeming to abate, we'll try to lower that medication and hopefully get them off. My goal as a nurse practitioner is really to keep you on the least amount of medications as possible and optimize your ability to function and manage MS. So, and then moving to managing modifiable risk factors, for me, this is where I put a lot of stock with respect to your clinical reserve. And in terms of modifiable risk factors, these are things that we believe have impactful influence on how you live with MS. And these would be lifestyle factors, things like not smoking, getting enough vitamin D, getting enough adequate, good quality sleep, adequate hydration, exercise, meaning you move more today than you moved yesterday, and diet. There's been lots of really interesting and intriguing research being conducted in looking at sugar as a pro-inflammatory instigator and sodium as a pro-inflammatory instigator and saturated fat. We also know historically that Dr. Swink did a lot of this work, albeit not terribly scientifically, but certainly did conduct studies, and a lot of his patients, in fact 95% of them, reported to feeling better on a very low saturated diet. So we're looking now at the gut microbiome and trying to determine how different diets affect the good bacteria and the bad bacteria in the gut and how that may influence the central nervous system. So these are the factors that I consider the modifiable risk factors, okay? Because we know if you smoke, it makes your MS much worse. If you have a lot of stress and you're not getting enough sleep and you're not exercising and you're dehydrated and you're eating poorly, these will all contribute to how you feel with MS, okay? So now kind of going back to building, the importance of building your healthcare team. I will say that in MS, it's a very different medical model, than most other areas of medicine, okay, in the sense that we really try to focus on being patient-centric in MS, and that the way I see it is when I'm in a room with a patient, there are always two experts, okay? I may have an expertise in the science and experience treating MS, but you also have expertise as someone living with MS, and you're also an expert in your body. No one will ever know your body better than you, and I rely on your expertise when we are formulating a plan, because that is invaluable information to me, is how you respond to things. I may know theoretically and scientifically how a drug is supposed to respond, but as you and I both know, science doesn't explain everything. And certainly your esoteric knowledge of your body and your intuitive knowledge of living with MS is invaluable. So when we look at the partnership in MS, you really are the center of the team, the coach, if you will, right? And so identifying who those important players are on your team is very much something that we help and hopefully facilitate you to do, all right? We look really to you as a whole person, and MS really does affect, yes, we know scientifically it affects the brain, the spinal cord, and the optic nerves, okay, if you want to be very academic and literal. However, the symptoms affect all of you, and certainly we can't dissect you. We can't dissect your brain and your spinal cord and your optic nerves from you, the person living with the MS, okay? And so we really try to utilize a team approach because that's the most comprehensive. And unfortunately, sometimes that can be certainly the most complicated because there are many cooks in the kitchen, if you will, and many people stirring many different pots. And so trying to make sure everybody's on the same page all the time can be a challenge. And sometimes it's really important to have case management, either through a social worker or a patient advocate, or sometimes it's even somebody you've identified in your personal life who's a really good secretary or a really good bookkeeper that you can kind of bring with you to appointments and who can help you organize and advocate on your behalf. Right? Coordination of communication and care is crucial, and certainly we really work hard to try to make sure that we are keeping your primary care doctor and any other doctors or healthcare team members abreast of how you're doing neurologically and from an MS standpoint. Okay, so this is probably the most important slide that you're going to see tonight. And it is really adopted from expert faculty opinion, and it's been presented at many, many MS meetings for healthcare providers Specifically, we use it all the time in the International Organization of MS Nursing when we're out in the community teaching nurses who work in neurology and nurses who work in MS, really to try to illustrate for healthcare providers out in the community is that this is really how we work in MS. It is very different from the traditional medical model of the doctor-patient relationship where the doctor is the expert, the patient is just the recipient. And the patriarchal kind of, I am the doctor, I'm telling you what to do, and you do it. That is not at all the way we work in MS, and it's very much a dynamic relationship and an ongoing one, certainly. So at the center is really you, the person who is living with the MS. And the thing that I really enjoy working in MS is that, with respect to my colleagues, is that everybody has a level of expertise and a sense of expertise. And I think we work well in that the neurologist is also a member of the team, as is the nurse, as is the physical therapist, as is the psychiatrist or the physiatrist or the social worker. It's not a triangle that you're seeing here. It's not there's somebody who's on top and everybody's below that person. It's really very much more that you're the center of the wheel or the hub, if you will, and we're all the spokes trying to move along with living with MS. So not every MS center has all of these individuals, and certainly it varies in regions. I've had the great fortune to work in here in Florida, as well as in the Northeast and in North Carolina, and in working in 3 different MS centers and 2 different private practices. I will tell you that it does vary significantly region to region and sometimes practice to practice. But the important thing is to identify, even if all of these folks are not under one roof, literally, is to be able to identify that they may be available to you, not necessarily under one literal roof, but maybe under one virtual roof. So we have, obviously, nursing at the University of Miami. We have myself and our infusion nurses and our clinical nurse, and we also have physical therapists and occupational therapists, and ability to refer to urology and orthopedics and neurosurgery. And we, in my area, I'm lucky enough to have internal medicine actually literally under the same roof as I am, and so we can very easily coordinate care with patients who have their primary doctor right there down the hall from me and then myself. But the important thing is just to identify who each of these people are and what they can do for you. So if you'll allow me, I'll just run through, kind of starting at 12 o'clock and run through, going clockwise, each person and what they may be able to provide for you on your team. Okay? So as MS nurses, they may be RNs or they may be nurse practitioners, advanced practice nurses. They may manage your MS. Okay, I see patients and manage their diagnoses, manage symptoms, and if I need to change disease-modifying therapies, I'll do that, or prescribe MRI. But we're here really to counsel and educate and promote health and well-being and wellness, despite having MS, and also to really act as a liaison between you and the neurologist. Right? The physical therapist obviously works very closely with a physiatrist, and a physiatrist is a doctor of physical therapy. So the physical therapist also can make an evaluation and also recommendations, and will also work through a therapeutic regimen during 1 to 2 times a week, doing different exercises to help promote strength and stretching. Certainly a psychologist or a neuropsychologist is very helpful to identify early on any cognitive impairment. And we work very closely with our neuropsychologist at the University of Miami. And ideally, if you haven't ever had a neuropsychologic evaluation, I encourage you to do so. It is a extraordinarily long testing process. Most neuropsychologists, if they're doing a comprehensive neuropsychological evaluation, it can be 6 to 8 hours. They generally break it up into 2 days of testing. But it is very helpful to identify early on a baseline by which comparisons can be made. And in my experience working with people living with MS, it's generally not weakness or disability that ends up causing people to have to change jobs or to seek disability. It's cognitive impairment or severe fatigue. And this can be very easily detected with the neuropsychological evaluation. And oftentimes, if you are seeking Social Security disability, they certainly want to have some input from the neuropsychologist, because if it's a weakness issue, they're going to see if you can't do some other form of employment. Okay, and unfortunately, we know a lot of people have fatigue and cognitive issues, and it's very helpful to have a neuropsychologist to be able to help kind of determine if the cognitive impairment is from depression, is it from fatigue or sleep deprivation, or is it truly an organic process where there's real cognitive impairment related to the disease. Occupational therapists are very adept at helping upper extremity motor strength and functionality. So occupational therapists can help with certainly if there's any problems with hand weakness or tremors. They can help identify and work with people, especially when it comes to things like your day-to-day functioning in a job where you might have to write or type or answer telephones. They can be extremely helpful to rehabilitate any upper extremity weakness. Okay. Speech and language pathologists also not only can test for speech and swallowing, but speech and language pathology also can help to detect cognitive impairment. And they also can conduct neuropsychological evaluations. They generally are not as in-depth or comprehensive as the neuropsychological evaluations. And quite honestly, a lot of times a baseline examination can be done by a speech and language pathologist because they can hit all of the top line issues usually in a much more accelerated fashion. It doesn't take as long usually to do the testing with them as it would to be have it done with a neuropsychologist. Urology is always helpful in terms of determining if there's any bladder dysfunction, if it's neurogenic bladder, or is it, in the case of gentlemen at every age, is it a prostate issue or is it a truly a neurogenic issue? Certainly as men get older, they can see some erectile dysfunction or issues with ejaculation, and that isn't always a clinical symptom of MS. That can be related to other issues, more so vascular sometimes than even neurological. Okay. Physiatrist, as I said, is a doctor of physical therapy, and they can make a comprehensive evaluation and look at determining if somebody would benefit from like an AFO or with orthotics or maybe a wheelchair fitting, and certainly can help if there if any type of ambulatory device is required or any type of travel lightweight scooter. They can do that type of evaluation. Psychiatry can be helpful in prescribing medications. I'm not sure in your area, but I know in Florida, where we work, the psychiatrists really don't, it's few and far between that you'll find a psychiatrist who actually does counseling. Most of them are doing psychopharmacology, where they're really managing medications. But we rely heavily on our social workers and also psychologists to do cognitive behavioral therapy, or talk therapy, if you will. Orthopedists can be quite helpful because as people develop gait impairments, they can certainly have a lot of orthopedic issues with respect to overuse syndrome with hips and knees and shoulders. And so they can be quite helpful, especially if people might have accelerated arthritic issues because of overuse. Social worker we discussed, they can also be quite helpful with insurance issues and navigating prior authorizations and certainly any financial hardships that might be occurring. Primary care physician really acts as a case manager, and of course the neurologist works quite closely, obviously, with diagnosing and with determining disease-modifying therapy and course and plan of care. And then the vocational rehab counselor, this is somebody who would be very helpful or useful in terms of if you are having challenges or struggles in your current employment. They may be somebody to counsel with to determine if there is some other type of employment that you might be able to perform optimally so that you don't have to leave your work. Or they can also be very helpful in requesting accommodations from your employer. So that's really a kind of comprehensive overview and really kind of at the 10,000-foot level of what the multidisciplinary team approach looks like in MS with all the different possible players, if you will. Kind of getting back and kind of starting to wrap up, in terms of MS nurses and nurse practitioners, we really are on your team to help promote your health and to identify comorbidities that you may have in MS and to make sure that you are engaging your primary care doctor and getting your yearly physicals and appropriate age and sex screening tests, and also to encourage you and provide hope that you can still attain health and wellness despite having a chronic condition. And I always tell my patients, just because somebody put a label on you as having a chronic illness doesn't mean you have to limit yourself to thinking that you're going to be chronically ill every day for the rest of your life. But you still can attain health and wellness despite having that label. I always say there are enough people in life who will put labels and limits on you. Don't allow yourself to be one of them. You want to make sure that you are actively engaging in wellness, and that is a multidimensional paradigm. So it's really, we define health in terms of your quality of life and your well-being. And I always say when I go to work every day, my two goals are this, is that one, I want to help you optimize your health and your wellness and improve your quality of life. And everything else is really academic. So we want to make sure that you're being provided with the appropriate amount of education and counseling, and that you also are receiving the support that you require so that you can successfully live and manage this disease. My nursing colleagues and I say we're kind of on the team. We're either considered the water boys or the cheerleaders. We're the runners, and we're the ones who are going to hold your hand and cheer you on. And kind of in closing, I just wanted to promote a couple of things again because it is MS Awareness Week. We don't want to forget the rest of your health being absolutely important and vital and certainly influencing and having a significant impact on how well you manage your MS. So the things that we know that absolutely improve living with MS is making sure that if you are smoking to try to quit. And there are many programs to help you do that successfully. Make sure you're getting your vitamin D levels checked annually and doing the necessary things to elevate that level. We have very good multiple research trials showing that the higher the vitamin D level, the less relapses and inflammation we see. And following a low-sodium diet also helps to promote that anti-inflammatory effect in the gut, as well as a low sugar, low refined sugar diet, and low saturated fat. Exercising regularly and daily, and this might be something as simple as breathing exercises, okay? But ideally, if you move and do more today than you did yesterday, you're always moving in a forward fashion. And what I mean by exercise is it doesn't mean you have to go to the gym or do anything rigorous. I just want you up, walking, moving. Even if you are somebody who has ambulatory challenges and you can't walk or you can't stand, if there's something you can move, move it. If you don't, you will lose it. Making sure you're getting good quality sleep, okay, which means we all turn off our computers, our televisions, and our smartphones 2 hours before bedtime. You know, most of you are gasping right now. I can't hear it, but I know you are. And also that you're adequately hydrated, okay? And I think probably the most important thing is a sense of purpose and knowing that you are much more than somebody who lives with MS. You have dreams, you have aspirations, and you have goals. And knowing that this is merely something that you have been challenged with. It certainly doesn't describe you or define you. And I always say that the challenges that you are given have been given to you, and you can and will rise above it. It's something every day you may be challenged with, but you are strong enough and you can do it. So I will close now and take the opportunity for questions. Casey, I'll turn it back to you. Casey?
Sorry about that. I was talking away, forgot to unmute myself. Our listeners who are online can use the raise hand button. That will allow you to send a question either by chat or by voice. I can bring you on the line if you click the raise hand button and choose to ask a question in that way. Do we have any questions? I'll get things started. You talked at length about the different specialties, and you mentioned that you don't have to have access to an MS center to have this sort of multidisciplinary approach. But for a person who doesn't have access to an MS center and they want to build this sort of multidisciplinary team, how do they get those medical professionals started on working together?
So that's a great question. And I think the first thing is just communication. And this is where really you have to almost be your own advocate. And that's when I said earlier about employing whoever is in your network of who is a really good either accountant, bookkeeper, or an attorney. Bring them with you to your appointment because you really want to communicate with your primary doctor and your neurologist first and foremost. Those would be the two people initially who have to communicate with one another. Is get the card from each of them, get a business card from each of them, and when you go to the appointment, hand it to your healthcare provider and ask them to please send a copy of their notes to the respective other healthcare professional, okay? And unfortunately, we live in such a fragmented healthcare system where you almost have to be the pigeon courier. in requesting these things. Unfortunately, we don't have an automated schedulized system where wherever you go, everybody has access to notes. So you literally have to formally request it. And it will probably require you to sign off on some forms at each of the doctor's office for HIPAA release, for medical records release, so that your healthcare providers can communicate with one another if they're not in the same healthcare system. That's the easiest way. And then secondly is that if you have the National MS Society, a chapter, or a social worker from the MS Foundation or MSAA, there are lots of nonprofit organizations that employ social work. You could ask them for their help, but generally speaking, you can ask someone to work on your behalf and to help advocate for those open lines of communication. Unfortunately, too, a lot of this is determined and now dictated by insurance. So you may have a healthcare provider in one healthcare system that's covered by your insurance, and a subspecialist like a neurologist or a physical therapist that's covered in a different healthcare system based on your insurance. And that's where it can be sticky, and that's really where you have to be an advocate for yourself. But I always say we don't live vacuously. It really does take a village, and this is where I would call on a support care partner to come with you to visit.
Okay. Any other questions, folks? You can use that raise hand button. I see that there's a question directed to me from Mary Lucia, and she asked, how can I get copies of the slides? At an earlier presentation, we discussed that they would be online. Yes, this is true. These presentations are being archived so that you will be able to watch the slides and listen to the audio on the Multiple Sclerosis Foundation's YouTube channel. We'll be doing that for all of the teleconferences in our National MS Education Awareness Month series. It does take a few days for them to get posted to the site, so keep an eye on it, or you can watch the foundation on Facebook, Instagram, Twitter, and we'll share when those videos are available. And the audio will also be rebroadcast from this program on MS Focus Radio, hopefully within the next few days, but definitely within a week. All right. Do we have any other questions? All right. I think that's all the questions that we have for now. I would like to mention again that this teleconference was part of our National MS Education Awareness Month series. Our next teleconference will be Thursday night. We invite you all to join us to find out more about all of the teleconferences in this series. You can go to msfocus.org and click on Events. That will show you everything that we have going on for the month. I would like to extend our sincere thanks on behalf of the Multiple Sclerosis Foundation to our sponsors for support of this program, to all of you callers for your support and participation, and especially to Jennifer Smrtka for a fantastic presentation. Thank you so much for the time that you spent preparing this and sharing it with us.
Thank you. It's my pleasure, and thank you again for the opportunity, and thank you again, all of you, for joining us.
So that's our program for this evening. Good night, everyone. Thank you for joining us.